Hi, good afternoon. My name is Naomi Valadez, and today I'm going to talk to you about my reflection on the round this week. And we're going to start about the first question. What are the main points of the readings? Well, the central of this argument is across the three texts that migration is not merely context to which health outcomes occur. It is self-determinant of health and deeply shaped by the legal, political, and institutional structures. And the article by Castañeda argued that public health is most moved away from the narrow frameworks that place that burden of the health disparities on the cultural or individual behaviors. And instead, they propose a structural vulnerability model that identifies the migrant policy, legal status, and systemic exclusions as adhering contributes to poor health among migrants. And the term that people from seeking care and limited access to insurance or emergency support and other example is the article by Fleshman that actually offer a case study of the irregular migrants in Israel and revealing how the deportability defines the consent right of the being removed that and from the country and affects not just mental health but every aspect of this of well-being. And they show that even when the services are technically available, barriers like fear, discrimination, and bureaucracy often prevent migrants from access of care. And the Israeli case reveals the paradox of the partial inclusion that where migrants are tolerated for the labor but denied full access to the rights and producing the permanent state of insecurity. An article by Badelet extends the argument in the Latin America context, emphasizing that migration must be addressed as struck no human rights frameworks and coordinate to action between governments, NGOs, and healthcare system. And she's argued that actually the fragmentation of the migration and health policies leads to dangerous gaps in the protection and the main takeaway across all the three stacks in clear. And if we have capable health outcomes for migrants, we need to treat immigration as a special case and just like as a central challenge of the public health in the 20th and the 21st century. Okay, continue with the second question. Was anything occur confusing to you and why? One of the most aspects conceptually complex ideas it present in the was distinction from between access to care and meaningful incision in the health systems. For example, in the Fleshman article described how the irregular migrants in Israel technically have the access to emergency care and NGO clinics, and but the constant or the threat of deportation combined with the systemic discrimination and meant many migrants to still avoid seeking care. And this raises a question for me and about what is it really means for care to be viable and its ability and now the fear of the stigma keeping people away. Additionally, in the Castaneda article, critique the overuse of the cultural explanations in health disparities. Initially, that's term and confused me, but because I always understood that cultural competence as a key element of the equitable care. But what they argue is the framing problems through the cultural on and like saying patient don't evaluate prevention or the complete diverse attention from the real structural barriers like poverty, racism, or legal status. And I'm showing me to me how even well-meaning interpretations can become harmful and if you ignore the larger context. And another complexity that came up is in the Vanderlight article that works in the idea of the intersectionality, the need for immigration, health, and labor, and human rights sectors to collaborate in creating inclusive systems. And while this makes sense in theory, I was left wondering how such a coordination happen in practice, especially in the political and stable or resources limited. And settings, this on-suite question makes me want to explore real-world models and where such intersectional approaches have to work here. Well, now continue with the third question. What was new to you in the issue? How you think? Before this reading, I although the healthcare is mostly logical and about the language support transportation or clinic hours. But this text helped me out to realize that structural conditions like law, citizenship, and social stigma and completely define whether the someone feelings safe as seeking of the care in the first place. And for example, if a person first begin to report it to immigration, even though the free clinic free like 10 years, this shifted my perspective from focusing the solely of health deliberate to thinking about the social ecosystem that was surrounding the healthcare. And Castañeda concept of the citizen as a gatekeeper to help, and particularly shailing me, I have not fully considered how healthcare systems often perceive as the neutral and actually produce exclusion based on the national and legal status. And this reframe how I see the term the universal healthcare, and it is not applies to the citizens or the documented people, that is not truly universal. And also new to me was the idea that migration is an inherently healthcare risk, and it becomes one when people are made invisible or impossible or criminalized. And this subtle but powerful idea to re-enter my thinking instead of saying migrant population as especially vulnerability to their cultural status. I now understand that the systems around them actively produce vulnerability through the policing and neglect, and that changed how I see my future role as a physician, and not just as someone treating the symptoms, but actually as someone who must understand and challenge the structures products and that disease. Well, now with the first question, was there anything you would like to explore and further or learn more about and why? These readings made me want to explore how the healthcare professionals can be trained in the structural competence, not just the cultural competence. The structural competence means understanding how political, legal, and economic structures shape the health, and not just recognizes the cultural differences. And for example, it means asking, does these patients avoid the cares because of the language barrier or because of fear deportation? And did they miss appointments because they are not non-compliant or because they work in two jobs so without pay time off? And I believe this kind of training could radically transform clinical encounters with migrant patients. And I'm also interested in learning more about models of care of the have successes in including on the migrants in nation health systems. And Vanderlip briefly the reference of the some Latin American countries that have adopted and include say, policies, but I would like to study those in deep and how were the political possible what were they trading of the combinations and understanding the real world information escaped from translating the theory into an action. And finally, I wanted to look into the role of the international human rights frameworks like the new on global compact of migration in holding on the ground. And as future health professionals, we need to know which levers we can pull up to fight for the systemic challenge. And finally, with the last question, we will list one specific example and an aspect of experience in your personal professional life that relate with the main topic. During a voluntary experience in the clinic and right here in the north, I encountered with a young woman from the state of Oaxaca who had migrated to for agriculture work, and she was 7 months pregnant and although visibly exhausted in pain, and she had avoided the medical care for the most of her pregnancy. And when we asked it like why she do it, she explained that she was afraid of the being asked because she don't have to secure to actually being or have secure like names. And we asked and she also didn't speak Spanish too well as she have their own language, and slowly making the idea of the navigating the medical visit even more overwhelming. And this experience brought these readings to life. It wasn't cultural or individual neglect that they delayed on the pregnant care, and it was fear insulation and structural inclusion. And the idea of the portability, which I just read in the Fleshman article, was real in her eyes, even in setting where the strict of the protection was legal now. And this made me realize how the healthy behavior is shaped not just by a risk, but by a perceived safety and dignity and belonging. Since then, I've been reflecting more than wise of the healthcare institutions committed on the migrant patients after the unintentional sending signals of exclusion and judgment. And this experience confirms where they are to argue if we don't resign, if we design our system around the justice, we will continue to live of the pull out.